What exactly do we know about this BA.2 Omicron variant and how exactly it differs from the BA.1 Omicron variant that a lot of people were infected with earlier this year?
Hi. I think there are some people who even suggest that perhaps we should not be calling BA.2 a subvariant of Omicron because it has pretty meaningful and substantial changes in the amino acid sequence, in the sequence that makes up the so-called spike protein and perhaps in some other areas. But whatever the terminology is going to have to be, what we do know about it is that from the data so far, the immunity that you get from a previous Omicron infection, or maybe one of the other subvariants, BA.1, seems to be sufficient to protect you against an early reinfection with the BA.2. We also know that the vaccines seem to be equally effective based on our own analysis of data from countries such as Denmark, which have had a major wave of BA.2, and also seeing some recent publications from Qatar. So from all of those perspectives, it suggests that based on the data so far, in the real world, the vaccines are similarly effective, and then an infection is about the same as if you have got a BA.1.
But Dr. Adalja, given what Sam just said, this is also coming at a time where many people's, protection against the virus is maybe waning because we're a few months out from the booster shot. So is that a concern to you?
It all depends upon what our goals are with this pandemic, because to me, I think it's inevitable that cases are eventually going to go up, that we're going to see more contagious variants like BA.2 appear. But if those cases are increasingly mild, meaning they don't require hospitalization, or they can be intervened upon with antivirals and monoclonal antibodies, and you don't see hospitals in crisis, I think that's the situation we always were aiming for with a virus like SARS-CoV-2, one that couldn't be eradicated or eliminated. It's going to be very important, though, for people who are not vaccinated to get vaccinated, and it's going to be important for immunocompromised people to be quickly linked to care if they get sick and to continue to be vigilant when they're in high-risk situations. But the virus isn't going anywhere. And I think this is sort of the new normalcy, that we will continue to see this become a seasonal respiratory virus that has ebbs and flows and hotspots that keep cropping up.
But when does it become an area of concern, Dr. Adalja?
To me, it becomes an area of concern when you see hospitals worrying about capacity, when they're worried about not having enough room to take care of patients. That, to me, is what this pandemic has always been about. That's when we're really in crisis, when we can't have the healthcare system functioning the way it should. And that's happened during Delta, that happened in the early days of the pandemic. It less so happened during Omicron because many of those cases were mild and not as sick as we saw in the past. But that's what we're trying to do, is tame the virus, shift its spectrum to the mild side. And I think it's unlikely that BA.2 is going to be able to crush hospitals in the U.S. because we've got enough immunity from infection and vaccination, plus tools like antivirals and monoclonal antibodies, that will likely see this shift to the outpatient side. And that's where we want to be.
Sam, I'd love for you to respond to that, especially because in your note with one of our colleagues as well, you talk about how COVID, we do have to start living with it, but we have to learn to live with it, but we can't ignore it. So does that mean we should still be having some of the precautions that we had, like masks, like, not gathering in big groups, being extra cautious on planes? What's your take?
Yeah, I think I have to say that Dr. Adalja explained it perfectly well there. Currently, our biggest issue is worrying about whether there's going to be a run on hospitals again and severe disease. But in terms of our behavior, I think what I think or anybody else thinks is kind of irrelevant. People have moved on. I think to roll back a requirement for masks again in public spaces, on public transport, etc., really enforcing it is going to be very tough unless there's a tangible feeling of danger out there that people will regard as. And we've told them enough times now that this is potentially a bit milder than the other variants so far, which is probably a lot to do with vaccination levels, etc. But I think one thing that we are not talking about enough is this issue of long COVID. Granted, there is a lot of hope and some data that suggests that people who are fully vaccinated, I want to stress again, people who are fully vaccinated, possibly needing 3 doses, have a lower risk of developing longer term symptoms. But there are still some, and there are all sorts of things that are coming out of the woodwork with regards to diabetes, brain issues, a lot of which are probably general reaction to a viral infection, I don't know about the details for a fact. But that's something that I think we can't forget. And if we have high levels of infection running around, even if we're not seeing hospitalizations, we need to keep a very close eye on that.
Sam, is that reason for a fourth shot then?
I'm not going to go there. I'm really sitting on the fence about fourth shots. There is little doubt in my mind that at some point, perhaps ahead of the winter, for the more compromised people, you want to call them immunocompromised because of disease or age, perhaps the fourth shot will be useful. But I don't know from the data that I'm seeing, again, out of Qatar, with the efficacy of a third shot, whether really, even against Omicron hospitalizations, whether really you need a fourth shot. And let's not forget, the effect of a fourth shot will contract again. It won't last very long against an infection. So we'll be constantly chasing our tail on that.